Okay, so now we will go to the second part of today. Ralph wants to present to us his thought and ideas about combination therapy in diabetes these days, 2020.
I'm not sure what I'm supposed to do. How do we get the screen up? Oh, a miracle.
Oh, you see, it's written combination therapy.
Yes. And can I make it move by myself?
Yes, you can. If it doesn't work, we'll make it for you.
Yeah, I can't make it move.
You change it now, no? Or it's
No,
my
no.
second. Okay, so just ask for.
Okay, can you go back to the first slide, please?
You'll have to say next.
Yeah, I can say next. All right. All right. So when Itamar asked me to do something, I thought about what I should do. And of course, Itamar never asks you to do something very simple. So I'm going to talk about what's the future for multiple therapies interacting in terms of preventing of cardiovascular disease. And obviously, there's no answer to this. So if we can go to the next slide, I had to call upon the great wizard. My dear friend has had to reach into his bag of tricks and sorcery to come up with an answer. If you look closely, you'll sort of, I think, picture who under all of that disguise is the great wizard. And the great wizard, next slide, said, as he always does, mirror, mirror on the wall, who is the best of them all? Next slide. So where do we start? If we're going to start now to think about combination therapy for cardiovascular disease, I think we have to start with the drugs with which we actually have some proven benefit. And in my opinion, there are three, and I've shown them here, the SGLT2 inhibitors, pioglitazone, and the GLP-1 receptor agonist. And you will note there's a pretty obvious exception here, and that is metformin, because I don't believe that we really have any data one way or another that in any definitive way tells us that metformin actually will prevent or will not prevent cardiovascular disease. Next slide, please. Next slide. So I don't have to detail what's on this slide because everybody who's listening in, I think, is familiar. We have very good studies with the SGLT2 inhibitors, I think unequivocally demonstrating cardiovascular protection, particularly with regards to heart failure. We have really good data with the GLP-1 receptor agonist. What people have forgotten that there are as much data with pioglitazone in terms of cardiovascular protection as there are with the newer drugs. And pioglitazone in the United States now is $5 a month. So this is a drug that really is quite acceptable. And then down at the bottom, I've put metformin. Just to point out that I think in large part we've given metformin a pass. It's been around for a long time. Of course, it's cheap. But in terms of what data that are out there, I think it's very meager. Everybody wants to quote the UK PDS study in which there were 342 obese patients in whom there was a decrease in a multifactorial cardiovascular endpoint. But in that same UK PDS study, there was a second arm in which metformin was added to sulfonylureas. And in that second arm, there was a 39% increase in cardiovascular mortality. Now, since sulfonylureas are the other drug which most commonly used in the US and throughout the world, it seems to me that people have neglected that there is within UK PDS is much data saying that metformin can do harm as it can do benefit. In either case, I personally think that the argument that metformin has any benefit or lack of benefit is difficult to make simply because we just really don't have any data, and this study is not going to be done. Next slide. So what do we know? Let's start with the SGLT2 inhibitors. First, we know they correct this novel pathophysiologic defect that we described many years ago at the level of the kidney. And by opening and lowering the threshold at the level of the kidney, they induce glucosuria. As the blood sugar level comes down, we improve insulin sensitivity in muscle, and we improve beta cell function. This is removal of glucotoxicity. We have a reasonable drop in the A1C. We lose calories in the urine, so there's weight loss. Since we're going into a little bit of negative sodium balance, there's a decrease in blood pressure. This drug or class of drugs is very safe. There's no hypoglycemia. And we can combine this class of drugs with any of the other drugs that are available, since they work by a totally different mechanism. And many years ago, when these drugs were introduced, there was the hope that there may be some cardiovascular benefit, and we now know that, in fact, this is proven. Next slide, please. Can we go? Yeah. And so rather than showing you each of the individual studies, I've just put them all together here, the clear yellow, canvas green, infrared, and purple. And in my opinion, these drugs basically all do the same thing, and the difference that we see in outcomes are more related to the patient population that was studied rather than the drug that was used. So all three of them decrease MACE, not statistically significant in the DECLARE. If we look at cardiovascular death, it looks like there may be some differences, but I think we all know that for the EMPA-REG outcome study, virtually 100% of these people had a cardiovascular event. So this is the sickest population one would expect. And then that you might see a greater benefit in cardiovascular death. In contrast, in DECLARE, this was the least sick population. So we see the least benefit in terms of cardiovascular mortality, and an intermediately sick population in the Canvas trial. All three of these drugs decrease myocardial infarction. I think what was surprising to all of us and still not well understood is the lack of benefit in terms of stroke. And then major benefit in protection of heart failure, very similar with all three of the drugs, and a huge benefit in terms of cardiovascular protection. So this class, I believe, is now very, very well established as affording cardiovascular protection, and both from the atherogenic as well as from the myocardial, as well as from the renal standpoint. Next slide. Okay, so you're going to have to click. Yeah, you can go through all. Might as well just put them all up, since I can't take you through all of them. So what have we learned in terms of their mechanism of action? I think that the major mechanism by which you get this cardiovascular benefit is related to hemodynamics. These drugs cause mild intravascular volume depletion, leading to preload and afterload reduction. So we get a nice decrease in blood pressure. And they're also, with all three of the drugs now, well documented decrease in arterial stiffness, particularly in the aorta. So there's very big afterload reduction that comes from this, as well as from the decrease in blood pressure. And what's interesting is that there's no increase in heart rate, suggesting that there may be a decrease in sympathetic nervous system activity. And in fact, we are in the process of completing studies now with norepinephrine turnover. And indeed, it does look like the SGLT2 inhibitors do decrease norepinephrine turnover. The other hypothesis has to do with the metabolic changes that occur. This is put forward by Bob Henry and Ellie Farinini a number of years ago. These drugs switch you over to ketone metabolism. Ketones are a preferred fuel that are taken up by the myocardium. And when burnt, you generate more ATP with less oxygen consumption. This is one potential benefit, or as we have now data that suggest it may simply be due to the fact that you're giving another metabolite that can be taken up by the myocardium rather than substituting, say, ketones for glucose metabolism. You're just presenting more fuel to the myocardium. And these are the two major theories, although I have to say that their recent data, I think, is now fairly strong that these drugs can inhibit the sodium hydrogen ion exchanger, this being an off-target effect of the drug. There are many other factors that could be playing a role, but I think right now the hemodynamic, metabolic, and the sodium hydrogen exchanger are probably the most commonly put forward or thought to be important mechanisms by which see these benefits. Next slide. So another major advantage of the SGLT2 inhibitors is their proven renal protective effect. When I went to Bristol Myers Squibb in 1992 with the idea that the SGLT2 inhibitors would be effective in terms of improving glycemic control, I also predicted, based on the Brenner hypothesis, that these drugs would, in fact, provide renal protection. And we now know, in fact, that that's true. I think that the Brenner hypothesis and tubular glomerular feedback is an important mechanism, but clearly this is a pretty narrow view, because we now know there are at least 7, 8 different mechanisms by which these drugs provide renal protection. Next slide just summarizes what we knew from the cardiovascular outcome trials. There were 3 of them: the EMPA-REG, CANVAS, and DECLARE. Secondary endpoint was a composite of renal disease, including end-stage renal disease, renal death, doubling of your serum creatinine, and macroalbuminuria. And if you look to the right, in all 3 of these studies, if we look at patients with established cardiovascular disease, there's about a 55 here, 0.55 hazard ratio, 45% decrease in this composite outcome. If we look at patients with risk factors who didn't have an MI or stroke to get in, of course, EMPA-REG drops out because those patients all had a cardiovascular event. Again, you see the hazard ratio is 0.55. So we knew from the secondary endpoint that these drugs were going to be cardioprotective. Next slide. And we now know we have 2 studies showing that, in fact, in a prospective study, we have credence with canagliflozin, and then we have DAPA-CKD. I'm not going to show you all the data because you know the data. The interesting thing in DAPA-CKD is that dapagliflozin was equally effective in people with diabetic renal disease, as well as people with other causes of renal disease. So if you just think of all of the benefits of this class of drugs, there are benefits at the level of the kidney, benefits at the level of the myocardium, and all of the other metabolic benefits. In my opinion, this should be a drug considered by first-line therapy and is far superior to metformin. Next slide. Now, next drug on the list is pioglitazone, an old drug which unfortunately has fallen out of favor for wrong reasons and misconceptions. But the drug causes a durable reduction in A1C, probably better than any of the drugs that we have. It improves insulin sensitivity, but its major mechanism of action is to improve insulin secretion, something that's not very well appreciated. Reverses lipotoxicity, so it's mobilizing fat out of a lot of organs, including out of arteries. It is the best drug we have for the treatment in NASH and NAFLD. And not surprisingly, we have a number of positive cardiovascular outcome trials. We have PROACTIVE, IRIS. We have the FDA analysis of all the data that Takeda submitted to them. We have multiple meta-analyses. We have real-world studies. To me, the data are pretty clear that this drug decreases cardiovascular events. And we have 2 studies showing anatomical regression. And my prediction is, and this is a paper that's recently published in Diabetes, that this will be the best and maybe only drug that improves diastolic dysfunction, for which we have really no evidence that any other drugs. We'll see what happens with the SGLT2 inhibitors, but I'm a little bit skeptical that those studies are going to be positive. Next slide. So, just to review briefly for you, the proactive data are shown to the left, hazard ratio 0.84 for the MACE endpoint, statistically significant. Everybody knows that this was the secondary endpoint, and the primary endpoint included peripheral vascular disease, was not positive when included, and therefore not approved by the FDA. If you look to the right, this is a meta-analysis done by the FDA. This is taken from the FDA website of all of the studies that Takeda in developing the drug in the US sent to the FDA. To get into these studies, you actually could not have a cardiovascular event. This is primary prevention, hazard ratio 0.75. So whether you already have an established event, or whether you are diabetic without an established event, pioglitazone is shown to be effective in reducing recurrent events, in particular the MACE endpoint. Next slide. Next slide, please. Now we have the IRIS study that was published several years ago in the New England Journal of Medicine. This has taken us another step forward, because in the IRIS study, to get into the study, you could not be a diabetic. You had to be insulin resistant. And I believe that insulin resistance is the underlying disturbance that plays a major role in the development of atherogenesis. And in this group of non-diabetic insulin resistant individuals who had a previous stroke or TIA to get in, hazard ratio is 0.76, 24% decrease in cardiovascular events, clearly demonstrating that the benefit of pioglitazone has nothing to do with lowering the blood sugar. So how does pioglitazone do this? Next slide. It, of course, is working through PPAR activation. And once you activate PPAR, there are a whole host of good things that occur within the cell, including reduction in inflammation, decreased reactive oxygen species. I could go on and on. Improvement in insulin sensitivity, endothelial dysfunction improves. We have an increase in nitric oxide, which is one of the most powerful anti-atherogenic molecules in the human body. The anti-inflammatory effects are manifest by the decrease in C-reactive protein. Reversal of lipotoxicity. It mobilizes fat out of all organs in the body. And what I think people have forgotten, particularly in the cardiology field, is that the most abundant fat in arteries is not cholesterol. If you go back to the 1940s, where we didn't have all these sophisticated measures, and you just take atherosclerotic plaques and you grind them up, the most predominant fat are free fatty acids. Pioglitazone dramatically reduces free fatty acids and mobilizes fat out of arteries, providing a potentially another important mechanism by which we get a reduction in atherosclerotic complications, reduction in blood pressure. Diabetic dyslipidemia is corrected, and importantly inhibits the MAP kinase pathway, which is the molecular pathway involved in atherogenesis. So lots of protective effects from the atherosclerotic standpoint. And as you think about these effects are very, very different from the SGLT2 inhibitors. Next slide. So because pioglitazone and SGLT2 inhibitors from the cardiovascular standpoint seem to exert their benefit by very, very different mechanisms, this is, in my opinion, a natural combination of drugs to use together. You'll also get additive effects on blood pressure, additive effects to lower the A1C. And I might also point out that if you put a GLP-1 receptor agonist or a DPP-4 inhibitor or metformin with an SGLT2 inhibitor, the additional drop in A1C is really quite minuscule. It's in the order of 0.2 to 0.4. Whereas if you put pioglitazone with a GLP-1 receptor agonist or an SGLT2 inhibitor, you get a completely additive effect. And I think this has to do with some of these unique mechanisms of action. The SGLT2 inhibitor will prevent any fluid retention that goes with pioglitazone. It'll also prevent the weight gain, although weight gain, in my opinion, is a cosmetic issue, not a metabolic issue. So when we think about combination therapy for prevention of cardiovascular disease, it seems to me that the SGLT2 inhibitor with pioglitazone is a natural combination. Next slide. Now, what about the GLP-1 receptor agonist? Above and beyond, and we'll get to the cardiovascular benefit in a moment, these drugs effectively reduce and, more importantly, maintain the reduction in A1C because they, like pioglitazone, are the only drugs that have a major effect to preserve beta cell function. They promote weight loss. They correct at least 6 of the pathophysiologic defects that are present in the ominous octet. Like the SGLT2 inhibitors and pioglitazone, no hypoglycemia. Other than the GI side effects, they have an excellent safety profile. And of course, everybody knows now that they reduce cardiovascular events. Next slide. And so I've put on this next slide all of the big studies together, going from left to right, liraglutide, semaglutide, exenatide, and to the far right, dulaglutide. And they all have a hazard ratio that's somewhere between 0.75 and 0.85. The only one which was not statistically significant in terms of the MACE endpoint was the Bidurion study. It's the third one over. And in a reanalysis of these data by John Buse, once you take out the dropout of SGLT2 inhibitors, the Excel study becomes markedly positive. So I think that the data are pretty clear that all 3 of these drugs are good in terms of cardiovascular protection. Next slide. And what about their mechanism of action? We know a lot less about their mechanism of action in humans because it's very difficult to get to the heart. But at least in animal studies, and there's a nice review by Drucker that goes through all of this. There are anti-atherogenic effects, there are anti-inflammatory effects, there are antioxidative effects, and anti-thrombotic effects. Now, we also know that there are GLP-1 receptors in the human heart. I think Drucker has pretty clearly shown this. The problem is we don't know exactly where these GLP-1 receptor agonists are located, so that there is the possibility that there are direct effects on the cardiovascular system. These drugs are very good at promoting weight loss, which would be beneficial from the atherogenic standpoint. They decrease quite markedly postprandial lipemia, and they decrease the blood pressure. So there are a number of potential mechanisms by which these drugs can afford cardiovascular protection. And again, you don't see the separation of the curves until you're out to 1 to 2 years. Very different from the SGLT2 inhibitors. Again, suggesting very different mechanism of action. Next slide. And if they have very different mechanisms of actions, then it seems reasonable that you can put these 2 drugs together. To the left, to get cardiovascular protection, in the middle, to promote weight loss, and to the right, to improve glycemic control. So whether we're thinking about sort of the metabolic non-cardiovascular effects, or whether we're thinking about the cardiovascular effects, this seems to me to be a natural combination to put together. Next slide. So come back to metformin. I told you earlier, I didn't put metformin in as a potential consideration because I really don't believe that there are data out there. We discussed the 342 obese drug-naive patients in which there was a decrease in a composite endpoint of cardiovascular disease. But I also pointed out to you that when that same study, when metformin was added to sulfonylureas in a much larger group of people, diabetes-related mortality increased by 39%. So with the newer drugs, I really believe that it's time to start to think about using these drugs in place of metformin. Of course, cost is always an issue, so I'm not negating cost. But if we actually think in terms of what do these drugs really do, metformin would have to be number 4 on my list of good drugs. Next slide. So let's come back now to the wizard. So what is the wizard's prediction? What combination of drugs should we be using or thinking about using in people with cardiovascular disease or people at risk for cardiovascular disease? Next slide. So what are the potential combinations? Pioglitazone, an SGLT2 inhibitor, for which I've given you, I think, lots of reasons why this is a good combination. Pioglitazone and the GLP-1 receptor agonist, lots of reasons for using these two together. SGLT2 inhibitor and a GLP-1 receptor agonist. So what is the answer? Okay, well, I think Itamar will like this. Next slide. We need to think about something which I call individualized therapy for cardiovascular disease. Itamar probably calls this personalized medicine. The ADA's interpretation of personalized medicine is a total joke, in my opinion. We know what are the pathophysiologic disturbances. The ADA has never said, and this is true for the ASD, that you should pick a drug based on the underlying pathophysiology. That's truly personalized medicine, okay? So what do I mean by individualized therapy? Next slide. So we know from many studies that have carried out that statins are much better for preventing recurrent myocardial patients in patients who've had a previous MI. Similarly, if we look in the hypertensive field, antihypertensive drugs are better for preventing recurrent stroke in patients with prior stroke. So we should look at these 3 classes of drugs and say, what are they best at doing? Because it's very clear that the 3 classes of drugs have very, very different effects depending upon whether you're presenting with a previous cardiovascular event and whether the event is an MI or a stroke. So for instance, in proactive, if you got into proactive because you had a stroke, pioglitazone decreased recurrent stroke by 47%. So to me, this is kind of a natural drug to be using ahead of the other drugs in people who've had a previous stroke. It also decreased myocardial infarction in people who had an MI by 28%. So pioglitazone seems to be a drug that could be used in people who've had either a stroke to get them into the study or who had an MI. So let's go to the next slide. So here now, what I've listed for you are the major problems: stroke, MI, cardiovascular death, heart failure, and renal outcomes on sort of y-axis. And then across the top, I've listed for you the 3 drugs. So what about stroke? Next slide. If you look at SGLT2 inhibitors, clearly these drugs really haven't done much for stroke, as I pointed out earlier. Very surprising, because they lower blood pressure, which is a major risk factor. So if we have to pick a combination in someone who had stroke, I would go with the GLP-1 receptor agonist in pioglitazone. Now, what about myocardial infarction? If we go back to the studies, all of the studies show that whether you're using an SGLT2 inhibitor, a GLP-1 receptor agonist, or pioglitazone, that they all benefit. So you could pick any 2 of the 3 in terms of prevention of stroke. Well, cardiovascular death. Well, if you're dead, I don't think you have to worry too much about which drug you're going to pick, okay? Heart failure. No, go back up one. Heart failure. Of course, the SGLT2 inhibitors are really the superior one here. I would say there's modest data for the GLP-1 receptor agonist. And of course, pioglitazone is not a drug you're going to be using in people with heart failure. So if we're going to use combination therapy here, it's going to be an SGLT2 inhibitor and a GLP-1 receptor agonist. Now, what about renal outcomes? We don't have any data with pioglitazone, but we have very good data with the SGLT2 inhibitors. And I would say that the little red box on the GLP-1 receptor agonist, I put it there, but to me, this is very misleading. I am not at all convinced that we have good data that GLP-1 receptor agonists are going to prevent renal disease. Most of the positive outcomes are related to proteinuria, and particularly microalbuminuria, which is not really a good risk factor for renal disease in type 2 diabetics. And I'll come back to the renal outcome of what might be the best combination therapy in a moment. Next slide. No, we got to go forward. Yep, keep going. Yes. So what are our options here? So what does the wizard say? Well, for stroke, it should be pioglitazone and a GLP-1 receptor agonist. For myocardial infarction, pick any two of the three. If you want to pick all three, I think that would be a great idea. Heart failure, SGLT2 inhibitor, GLP-1 receptor agonist. For renal disease, as I said, I'd come back to this, we need to have different approach. So the SGLT2 inhibitors clearly are the drug of choice. I'm not at all convinced that the GLP-1 receptor agonist really going to have a major benefit. But of course, all of our patients should also be on an ACE and an ARB. And then now with the Fidelio study, it looks pretty obvious that the mineralocorticoid receptor agonists are going to come into play. So I think we're going to be looking at triple therapy with SGLT2 inhibitors, ACE ARBs, and the MRAs. Next slide. So what is the optimal therapy? Well, of course, you knew what the wizard was going to say. Optimal therapy is that you should be using all three of these drugs. And I would even argue that these should be the optimal therapy for newly diagnosed type 2 diabetic patients, because these are the drugs that really correct the underlying pathophysiology. So with this, I think the wizard now is going to turn off his crystal ball. Of course, we need a long-term outcome study to prove whether the wizard are right or wrong. Whether we'll ever see a combination long-term cardiovascular study, however, remains to be seen. So who will then ever deny that the wizard is correct?
Thank you, Ralph, for a fantastic summary.
Hope you liked the wizard.
No, this was really a great summary. And in spite of the fact that, you know, we in a way know it all, you summarize it so well and you organize it so well. And you revive the pioglitazone, which in a way is hardly used worldwide. And we're a little bit late in time. Anybody want to comment?
Very quickly, if I may. I mean, that was wonderful, Ralph. That was the best of this particular talk. I've heard of most of it before. I've heard for a long time. What I'd love to, there's so much in it, though. It would be stupid to nitpick bits and pieces for criticism. What I'd love to do is to lecture alongside you with your slides, you saying something, let me to each slide.
We'll do it.
There are a lot of detailed criticisms one could make of individual bits. If I was to come up with one, I don't believe SGLT2s are good at protecting against myocardial infarction unless you have a risk of heart failure. And I think that is very important. And I agree with you, the evidence that GLP-1 protect against renal decline is largely absent.
I wouldn't disagree with you on the first comment. And that's in a paper that's going to be published soon. That is the really high risk group.
Ralph, just a brief comment. Congratulations, but I really enjoyed it. Unfortunately, I joined in the second half of your presentation, but it was really very good. I think that the end of the story is individualization for cardiovascular prevention. It's absolutely right, but in practical terms, I think very difficult to place in practice, in particular with a large number of patients that are affected. And also the dichotomy between the diabetologist and the cardiologist. So it's all fine, but then I think that before it comes like a real opportunity for patient, we have to wait a long time.
Cardiologists are way ahead of us. The European Cardiology Society is already thrown metformin.
Yes, I know. But they actually, the point is that it's not only the cardiologist, it's also the GP that has to help us. And I mean, to follow all this is not easy.
Of course.
Yes, Dr. Sabo.
Yes, I just wanted to have a comment on Ralph A.Defronzo. Great presentation. It was fantastic. We enjoyed the presentation. Just this pioglitazone usage in India is very high. It's not like that what you were telling, that in many parts of the world it is not used. We use it very often, and many of our patients, as we consider that highly insulin resistant, and it is still considered as one of the first combination to be started along with metformin. And now with the use of SGLT2, now it's like a combination which we use to most of our patients is a metformin, pioglitazone, and SGLT2 inhibitor. I just wanted to have that, paper which shows that pioglitazone improves the diastolic dysfunction. That is there any big study to support it that diastolic dysfunction is improved by pioglitazone?
To my knowledge, the only paper is our paper in diabetes care. And I think that heart failure with preserved ejection fraction is something that clearly we don't have any treatment for. And as you probably know, Boehringer Ingelheim has already now increased their sample size and extended the study for a year, their preserved ejection fraction study. What that says to me is they're not seeing the kind of overwhelming results as they saw in heart failure with reduced ejection fraction. So heart failure with preserved ejection fraction to me is the metabolic syndrome. This is the combination of diabetes, hypertension, dyslipidemia, etc., that's been going on from the time you make the diagnosis of diabetes. So it's a very, very different disease, and I think it's quite possible not going to be affected in a big way by the SGLT2 inhibitors. And I actually would even hypothesize that the drug that's going to be the best is going to be pioglitazone, but of course not giving it to someone who's got class 3-4 heart failure by starting early when the people don't have a major cardiac problem. You potentially could prevent it in the future. Now that's a hypothesis, but something that's worthwhile exploring.
Thank you, Ralph. Anybody else?
May I, Antonio? May I?
Yes, please go on.
Just a very short comment is that Ralph, also this starting with the early combination is also the best way to control hyperglycemia, which at the end of the day is still important for the prevention of microvascular complications.
Preaching to the God.
Yeah, no, because, okay. And the second is, I think that according to your presentation, the only choice is a triple therapy. Why? Because if you want to personalize the cardiovascular prevention, and probably only God knows which kind of complication you can get, it's very complicated at the beginning to decide to prevent stroke much more than prevent myocardial infarction, then to choose between different double combination. So I think that the best opportunity is to have a triple therapy from the beginning in order to cover all the possibilities. Otherwise, it's complicated to really individualize the cardiovascular prevention.
Well, we've been doing this for over 10 years. So it's just,
Larry,
of course, agree with you.
Larry, your thoughts?
Yeah, so totally agree. Great talk. I mean, I often quote Scott Grundy, who many of you will know, very American lipidologist, who wrote an editorial a number of years ago saying that whether we incorporate a therapy or not should not depend on the wisdom of the investigators. And right in the proactive study, had they chosen a better primary endpoint, no one would be arguing whether we should be using PIO or not. And it's bizarre. So yes, you know, for regulatory purposes, you have to go primary endpoint, but there should be some common sense here. So I agree with you. Just an aside, when you talk about the Emperor Preserve trial, I mean, hopefully BI is not aware of the results as they increase the sample size. I'm assuming it's because of a lower than expected event rate,
Yeah.
but we have to assume the investigators are blinded to the ongoing results.
Let's hope.
Right,
No,
let's hope. No, I believe it will work also there, also with preserved ejection fraction, not as robust as with reduced.
Yeah.
And Stefano, are you still with us?
I think he mentioned he had something.
I'm here.
Stefano? Yeah, you want to comment?
I mean, you know, Ralph is usually very convincing. And just wondering, you know, if just based on the evidence, we should just go all of us, you know, for empagliflozin because it's just dropped the cardiovascular mortality, which is even more important, you know, than a stroke and myocardial infarction and heart failure. But it's a sort of a joke. You know, the point, Ralph, you know, is usually taking very strong position. I still do see some potential for metformin. For the same token of discussion that we have been discussing before, you know, proactive study was unfortunate because of the selection of the primary endpoint. Metformin, unfortunately, will not have any large cardiovascular outcome trial. But if you put all the data together, I think there is still some value there. And I think that, you know, I will keep that on board for a very simple reason that the triple therapy that Ralph is proposing must be very effective, but it's going to be very expensive. And in spite of all the argument that you can bring up in terms of saving money in reducing cardiovascular outcome, still many health systems will still be looking at how much money you're going to spend today and not how much money you're going to save tomorrow. So with all the educated guess and given the variability and the difference in the different countries in the world, I think this is still a possibility, and I would sort of keep metformin on board for another while, personally.
Yeah, so as I said,
Stefano, 1 minute, Ralph. I want to ask Stefano, what do you think about the combination of pioglitazone with GLP-1 in patients who experience TIA or CVA?
You know, Itamar, I mean, it's fine, but you know that I'm very much, you know, in favor of early improvement and early treatment for people with diabetes. And if I just look at all these, the new therapeutical opportunities that we have, I do still believe, and I have a sort of a, you know, bias, considering that we may have now treatments that may have quite an effect on a very important complication in diabetes, which is diabetic nephropathy, which per se may generate quite a lot of cardiovascular risk. And in fact, low glomerular filtration rate, albuminuria are independent cardiovascular risk factors. So what I do see is a very early positioning with the SGLT2 inhibitors. With the advantage that they are oral drugs, and we still have to deal with some resistance with injectable. And they also make a nice combination, for instance, with metformin, because as Ralph showed, the SGLT2 can increase hepatic glucose production and to some extent, you know, offset some of the glucose lowering efficacy. But metformin may oppose to that effect, and because of that, you know, enhance the reduction in the hepatic glucose production. And if you want just discuss in terms of the pathophysiology, there are some claims that metformin may increase the expression of GLP-1 in the cells of the intestine, and because of that, you can also get can bring home a little bit of a increase in GLP, the circulating GLP-1. So early on, I would say that metformin and SGLT2 can be quite effective and also very safe.
Thank you. Guang, you want to add something before Guang? Professor Nin? Okay, he's not with us. So, Ralph, maybe you'll summarize this discussion.
Sure. You know, as I said from the beginning, that cost is always going to be an issue. And I think what we've failed to separate in all of these discussions is what do these drugs do and what do we know? Okay. We have no data, in my opinion, what metformin does in terms of protection against cardiovascular disease. For sure, this drug is not an insulin sensitizing drug. It cannot get into muscle under any circumstances because muscle doesn't have an organic cation transporter. And anybody who thinks that it's an insulin sensitizer is just really, it shouldn't be in the diabetes field, quite frankly. The drug works on the liver. It does not preserve beta cell function, okay? So metformin is not going to go away. But in terms of what we know about this drug, in my opinion, it can't compare to what we know about the other drugs, okay? Which is not to say that everybody in the world is going to start triple therapy. Number one, because they don't understand what the other drugs do. Number two, the other drugs are expensive, okay? But in terms of discussion, I think it's very important that we understand the science. What do these drugs do? And unfortunately, many people, including many people in the endocrine field, don't understand what these drugs do. And on the other hand, there's cost. And they're always going to have to be weighed in terms of how you go with the patient, what can the patient afford. So my problem is that we don't discuss the science of what these drugs do and what's known. And that's a big problem.
Okay, thank you, Ralph. I suggest that with this we will close. We are much beyond the time that we planned, but I think it was very interesting. I hope you enjoyed very much the first session, and Ralph, you gave a great talk as always. And thank you very much. We will keep in touch. I want to involve you and think together with you about ways to change or to prevent obesity in the future in the world. Look, it is very ambitious, but I think we might do it somehow with what we have shown to you today. Thank you all.
Okay. Ciao, ciao. Bye-bye.
Thank you. Thanks for the organization, everybody.